Stones in the urinary tract is a common urological problem. The incidence depends on geographical, ethnic, genetic and dietary factors. Therefore, the prevalence rates for urinary stones vary between countries. In Western countries with a high standard of life, renal stone prevalence is quite high, more than 10%, and there has been an increase over the last 20 years. There are several different types of stones in the urinary tract, and there are 4 main groups. The first group, which is also the most common group, are the calcium-containing stones. For example, due to low intake of fluid, the concentration of small crystals in the urine increases, and formation of calcium-containing stones may then occur. The second group of stones are the infectious stones. They are caused by bacteria producing an enzyme called urease, which are causing the stone formation. The third group of stones are composed by an excess production of uric acid, which, for example, is commonly seen in patients with gout. The fourth group of stones are the genetically caused stones. For example, cystine stones that are caused by an excess excretion of cystine in the urine. This group of stones is very rare. The stones are formed in the calyces or the renal pelvis of the kidney, that is up here. If the stone will fall down into the ureter, that is here, it will cause an obstruction of the urine flow and an acute onset of flank pain will occur. The diagnosis is clinical, but a non-contrast enhanced computed tomography is the best imaging modality to confirm the suspicions of a stone in the urinary tract. When a patient comes to the emergency with this type of acute pain, a medical history is taken and a physical exam is performed. It is typical that the patient will walk around in the room due to the pain, and when a percussion is performed over the position of the affected kidney, that is, here in the flank, the pain will get even worse. It is common with microscopic hematuria, but also macroscopic hematuria may be present. Pain relief is the first therapeutic step, and a non-steroidal anti-inflammatory drug is the best choice. This medicine is given either intramuscular or intravenous. Patients that respond to the pain relief treatment may go home with painkillers and do this non-contrast enhanced computed tomography later on. The CT scan can detect all types of stones, determine the stone size and the stone density, all factors that may affect the choice for further stone treatment. For the patients that do not respond to adequate pain relief treatment, it is better to do the CT scan immediately to confirm the correct diagnosis. Some patients may even need to be admitted to the hospital due to their pain. If the patient is in a lot of pain and a high grade of obstruction is found on the CT scan, the patient may need a decompression of this obstruction with either a percutaneous nephrostomy or an inner stent. The percutaneous nephrostomy is placed through the skin into the kidney and the renal pelvis like this, and the urine will then flow out into a bag on the outside of the patient. When using an inner stent for decompression, the stent is placed, you go in with a cystoscope right here, and you will place the stent between the renal pelvis and the bladder in the ureter. If the stone is less than 5 mm, it is most likely to come out by itself. But if the stone is bigger, some sort of intervention is more often needed. To help those small stones to pass, it is not uncommon that the patient will receive an alpha-1 receptor inhibitor in order to make the smooth muscle of the bladder relax and therefore make the passing of the stone easier here at the urethral orifice, right there. Once the stone has reached the bladder, it will come out when the patient voids. The passing of the stone through the ureter may take some time, and during this period the patient may experience episodes of flank pain, which is then treated with painkillers. If the stone is bigger than 5 mm, it is likely that the patient will need some intervention so that the stone may pass. For stones that are located in the calyces, in the renal pelvis or in the ureter, a treatment with extracorporeal shockwave lithotripsy is a feasible treatment option. That means that an externally applied, focused, high-intensity shockwave will fragment the stone into smaller parts that may pass through the ureter and out. For stones in the ureter, it is also possible to treat with an Andaluminal stone treatment. You will then enter the bladder with an instrument. It's called a urethriscope. It will go into the bladder and into the ureter up to where the stone is located. Then the stone will be fragmented using either an ultrasound or a laser, and the small fragments may then be pulled out through the urethriscope. For bigger stones that may fill out large part of the renal pelvis and the calyces, that is, if you have a big stone formation up here filling out very big parts of this area, the best treatment choice is to do a percutaneous nephrolithotripsy. What happens then is that you, just like when you put in a nephrostomy tube, you will enter right here, through the skin, through the kidney, into the renal pelvis here with an instrument that is called a pyeloscope. And you will then use either laser or an ultrasound to fragment the stone into smaller pieces, and those smaller fragments will be taken out through the pyeloscope. The most feared complication to an obstructing stone disease is a pyelitis with an infected hydronephrosis secondary to the obstruction. This infection is a urological emergency, and an urgent decompression with either a nephrostomy tube or an inner stent is advocated. What happens is that you have this stone here in the ureter, and it will obstruct the urine flow down to the bladder, so there will be a hydronephrosis up here. That means that it will be swollen here, much bigger than normally. If this area up here, the urine here, gets infected, you will get this pyelitis, which is a life-threatening disease. The patient will present with high fever, chills, and a dull flank pain on the affected side. The patient may quickly become septic, and it is necessary to act immediately. The patient will be treated with a high dose of intravenous antibiotics and decompression of the obstruction, as already mentioned. Urinary tract infections may pose a serious health problem for patients with a high cost to society. Furthermore, urinary tract infections are the most frequent healthcare associated infections. Most of the uncomplicated urinary tract infections are caused by the bacteria E. coli. Throughout the world, there is an alarming increase in microbial resistance against common antibiotics used for treating urinary tract infections, something that may cause serious problems in the future unless this process is not stopped by the limitation of the use of broad-spectrum antibiotics in uncomplicated urinary tract infections. The most common urinary tract infection is the cystitis, which is an infection of the urinary bladder, commonly caused by the bacteria E. coli. The symptoms are urgency, frequency, and dysuria, that means pain upon voiding. In some cases, macroscopic hematuria will occur, and it is more common if the infection is caused by Staphylococcus saprophyticus. The diagnosis of a cystitis is clinical, and a dipstick urine analysis is routinely made to confirm the diagnosis. A urine culture is recommended in all cases, except for the sporadic uncomplicated cystitis in premenopausal women. The urine culture is made in order to be able to adjust antimicrobial therapy if needed. The treatment differs between men and women, which is also the case with the follow-up. For men, a longer course of antibiotics is advocated, and all men should be controlled after a urinary tract infection to rule out possible underlying causes for the infection. Pyelonephritis is a urinary tract infection affecting the kidneys. The symptoms are fever and flank pain, which may be accompanied by symptoms from the bladder. The patient often experiences nausea as well. The condition may be treated with oral antibiotics, but some patients are so affected by fever and nausea that they may need intravenous antibiotics for a couple of days before put on an oral treatment. The treatment period is longer than for a simple cystitis, and a more broad-spectrum antibiotic is used initially before sensitivity testing has been performed on the bacteria in the urine culture. It is sometimes difficult to differ the pyelonephritis against the pyelitis with an upper urinary tract obstruction, and imaging of the urinary tract may be necessary to rule out this life-threatening condition, as already discussed in the urinary stone lecture. Patients with complicated urinary tract infections may develop sepsis, which is a severe condition that may be life-threatening. The patients are treated with high doses of intravenous antibiotics and may, in the severe cases, need intensive care treatment. Urethritis is an infection of the urethra, which is characterized by dysuria and in some cases a purulent discharge from the urethra. Urethritis is commonly caused by sexually transmitted diseases such as chlamydia and gonorrhea, and the treatment should be accordingly. Acute bacterial prostatitis was previously a rather rare condition, but due to an increased amount of prostate biopsies used for the detection of prostate cancer, this condition has increased over the last years. The symptoms include high fever, problems voiding, and a dull pain in the perineal area. This is also a very serious condition where the patient may quickly become septic and should be urgently treated with intravenous antibiotics, which can be switched to oral treatment when the patient has improved and the sensitivity testing has been performed on the bacteria in the urine culture. Bladder catheter drainage is often needed for a couple of days. Chronic bacterial prostatitis is a low-grade infection that gives rise to voiding problems and pain in the perineal area for at least 3 months. The same symptoms may be caused by an inflammation of the prostate without a bacterial cause. For these patients with a chronic prostatitis, antibiotics may be given for several weeks, but if it do not lead to symptom relief in the patients, the problems are probably not caused by an infection. Epididymitis and orchitis are infections and inflammations of the external genitals and will be covered in that section.